Pleasure to see us here in Francis Crick House. I hope everybody managed to get a parking space, and if they didn't have too far to walk. I believe that some of us came here rather early to make sure we did. Having said all that, there has been a significant change to the agenda for today. As you know, the Health and Wellbeing Board has a responsibility for signing off a Better Care Fund, and I'm very pleased to say that there has now been an agreement reached for a Better Care Fund submission, of which the board will get a review and an opportunity to debate that, and in consequence the agenda in front of you has been amended so that we will spend the first hour and 20 minutes or thereabouts, which will allow us to debate this properly, make sure that we are comfortable with what is being proposed, so that the board hopefully will pass a proposition that allows the chair of the board to sign the formal papers which have got to be submitted on the 9th of January. If we could start, we'll take first of all the declarations of interest, and I've been asked to remind a number of the members of the board that they have still to actually formally sign their declarations of interest, although we have had them logged previously. So Peter Lynch, could Peter stand up? Where is he? Yeah, Peter is responsible for ensuring that all board members have signed, and it also requires the substitutes to ensure they have signed as well. It's a legal requirement, and I'm sure that within your own boards you have a similar process. So it would be very important if you could make sure that we've got that in place by the March meeting. Very helpful, thank you. As far as the council is concerned, the fact that they've signed theirs for the council doesn't mean they've got to do it again. We'll then move on to the apologies, and the list of apologies we've got is at very short notice. Unfortunately, Councillor Harker has got to go to a planning and housing review meeting, which is being held not too far away, but it's unlikely he'll be finished in time to come and join us. And Councillor Suresh Patel will stand in. Nick Petford has got to be in another part of the world, and in consequence will be substituted by Professor Carol Phillips, who we all know. A couple of other absences are David Kennedy, who's our Chief Executive Representative from the districts and boroughs. He sadly has resigned from the board, and his deputy at this stage is Norman Stronner. And Norman is on his way, I believe, and we'd welcome him when he comes.
We just received a note that Norman is unwell and is not able to join.
We've just had a note that Norman is in fact unwell and will not be joining us. So Chris, as the representative from the elected members, no doubt will talk with them. It also requires the chief execs of the districts and boroughs to agree a substitute for Norman. The other absence today is Peter Wojcinski, and again, Peter has resigned from the Health and Wellbeing Board on the basis of a conflict of interest, and then that's how he spoke to me about it. If you're looking puzzled, Carol. No? Right. And we have today Mitten Rupiorella, who is here as his deputy, and welcome both. Paul Farrandon is absent today. He has a trustees meeting, I understand, at the hospital, but fortunately Chris Pallow is here substituting for him. Welcome, Chris. Round the table, the only new faces are Martin Lord, who wasn't able to join us in September, but is now the representative for the voluntary sector. And I think that everybody else here is known to one another. Adam Simmons sends his apologies for being late, and we're here by 10:30, all being well. Carol.
Sorry, Chair. Can I just confirm that Pete Wojcinski has resigned as chair of the CCG?
Yes, and therefore representative.
So therefore, Mitten is here as vice clinical chair.
Fine. Of Corby CCG, yeah. Okay, no other apologies. Move on to the minutes, the ratification for and any follow-up actions, some of which have been superseded by the change to the agenda. If I could just quickly go through those. Are there any amendments that are required to the words that are printed? Then page 2. John?
Just to say that the LMC is the local medical committee, not the local medical council.
Very good. I'm sure that we can amend that. I don't know where Cheryl is, but page 3, 4, 5, 6, 7, 8, and 9. Do you agree I should sign these as an accurate record? Thank you. Actions emanating from that, are there any that are not covered by the agenda which anybody would like to highlight?
Yes, I have one, if I may. Robin?
Yes. Sorry, Paul.
That's okay. It's B2.2, an action for Adam and myself to follow up on 136s. I think the good news is that the work that's been done with the triage car, the support into A&E, has clearly almost eliminated any young person being held in a police cell. There is some discussion or debate around the recording of the numbers historically, and we do have an issue with some of the points that were made because we have no record of refusing beds. So we need to get clarity on that, and we've requested a meeting with Adam to get that clarity. But unfortunately, at the moment, we haven't had a date offered, but we will follow up on that. But the good news is that where we are sitting right now, I think we don't have an issue in the county.
Thank you. Any other points? Fine. If I could go to the point A4, a review of the terms of reference. A draft paper has been submitted, of which there are a number of changes that need to be made to it. Any questions or comments or queries that need to be raised at the moment? Darren, I think you... Yes, Darren?
Yeah. I mean, I had a conversation with a few people beforehand. I think it'd be useful if we could take this as a draft and with any comments and then bring it back, just to, I guess, coming from the point of how do we monitor that we're actually fulfilling our duties that are set out in the board. It feels like they could be consolidated a bit more so that it's sharper and more able to be monitored.
Okay. And that will be... Hakim, do you want to comment on that? No? Andrew Jeps, who's responsible for that, is here today. I'm sure he's noted the points that have been made, and I know you've had a discussion with him. Yeah. Can I propose that we actually table the final paper, having agreed it between ourselves, at the next meeting? Is that agreeable?
Yeah.
Thank you.
And I guess just covering, so we had agreed that there would be 2 representatives from NEN and 2 from Corby, so I know we'd agreed that. So, yeah, that needs to be changed.
Fine.
Sorry, can I check?
I think I was just looking through, and we'll look at the language around the GP consortia. That was the old language that was being used then at CCG. So how do we reflect the recent terminology that's there? So I'm sure we can feed back all the comments into it and just update and refresh them. Yeah.
Okay.
Thanks, Chair. The monitoring of the duty of the board would actually come in the performance framework, which we had to remove from this agenda because of the extended conversation on BCF. So it would be helpful in March if the board is willing to use that as a basis of conversation about how we actually look at this board strategy going forward, and looking specifically at the new financial year and the medium term after that. So I suppose what I'm suggesting is we might have a prolonged agenda item at the next board, just looking at, how do we look at what we've done, what have we achieved, where are we now, where do we want to get to in the near future.
Okay. For the members of the public who've just come through, to explain that there has been a significant change to the agenda, which the board members have got copies of, And effectively, we are going to now move to a discussion and update and review of the Better Care Fund, and also an update on the Healthier Northamptonshire. And the timing for that is from now through until the coffee break, which is planned to suit the debate and the discussion any time between 11:15 and 11:15. So we'll move. No, I'm going to invite Eamon, who is with us. So if I could, without further ado, invite Eamon Kelly.
Thank you, Chair. I will try and construct my observations in relation to the papers so that we can lead seamlessly into a focus on the Better Care Fund. But perhaps if I could just start by explaining to the board and to members of the public who are perhaps not aware that the focus of the group that I've been chairing has been on implementing those programmes of work that flowed from the challenged economy exercise that this health and social care system undertook earlier in the year, and that resulted in this proof of concept document, which I'm sure you'll all be very familiar with. And I think it is just worth saying that that document identified a financial challenge over a 5-year period of some 279 million, and that may have been slightly changed by the impact of the autumn statement, but it won't be significantly changed. And the programmes that we've described in this report account for only some 60 million or so, just over 60 million of that 279 million. So the bulk of the challenge, the financial challenge, does rest with individual organisations. But what characterises, and this is very, very important in the context of the Better Care Fund and what the Better Care Fund is trying to achieve. What characterises the work of the Implementation Steering Group is a compact that's been made between each of the health organisations and the local authority in Northamptonshire to work outside of organisational boundaries in the best interests of patients and the taxpayers. And that's the essence of what we're trying to do with the Better Care Fund. And that might seem to members of the public something that we should reasonably expect would be happening in every part of the country. But of course, those of you who work in the system know that we've been working in a system which is quite ambiguous in many ways. It's promoting competition in public services, designing different structures for organisational arrangements supporting different parts of the healthcare system. So there has been some ambiguity. But if we look at what the best healthcare systems are doing across the world, they do operate in a very integrated way, and competition and cooperation manage to coexist. And I think over the next 5 years, we're going to see those lessons being applied more and more in our country, in England, in the NHS. And Northamptonshire, through the work it's doing flowing from the challenged economy exercise, I think is going to be leading the way in that. And that's one of the things that we need to make sure happens. And as we move forward to implement the Better Care Fund, there'll be a real opportunity to demonstrate that. That said, just some high-level messages just to support the report. The first one is that we do need to power up the work of the programme. There's some very good work that's been done, but there is a need for more capacity to make things happen. This is a very large-scale transformational programme, and it won't happen solely with asking people in current jobs to do more. Now, I do want to emphasise that our clinicians working in the system, our patients and our public are our greatest asset, and we should be mobilising them fully to make sure we implement this successfully. But they will need some support. We'll need some external capacity. And the chief executives of our organisations have recognised that, and arrangements are being put in place to make sure that that happens. But it's going to be particularly important in relation, for example, to integrated care closer to home. There's a lot of excellent work that's been led by Angela and by Carol, identifying opportunities to provide for more care closer to home. Some of that is already happening, but there's more that could be happening, and we need to make sure, as we go into the new year, that capacity is there to use some management jargon, to implement rapidly some programme cycles and to review those, so that actually we do know whether or not the things that we believe will give better patient experience and better value for money out of hospital, by providing more out-of-hospital care, are actually happening, can be delivered and are true, or what do we need to do to make those happen successfully. So one of the key messages I want to leave you with now is we do need that rapid implementation and we need to be seeing that rapid implementation happening early in the new year. I think there is still going back to the key ingredients around clinical engagement and the involvement of our patients and the public, there is more work still to be done on that. The strength of any health and social care system will come from its clinical and professional leadership. And so I would encourage you to support lead clinicians in being able to find the time and taking that responsibility. The delivery, just focusing on better care, the Better Care Fund objectives, the evidence from across the world is that the delivery of significant change in access to hospital care will come about only if the clinicians in the hospital are playing as key a role in making that happen as are their colleagues working outside of hospital. So that objective needs to be owned as fully by clinicians in the hospital as it does by those people working outside of the hospital. And that, in many respects, does represent quite a significant cultural change, and in many respects also, at some point, it needs to represent practical changes in things like job plans, the type of people that we're recruiting to work into the system. And one of the things that the system should be seeking to do is to communicate those messages to clinicians that want to come and work in Northamptonshire, that that's the model of care that we seek to happen. So I think we need to see, in addition to really powering up capacity, we need to see a really ambitious programme around clinical leadership, supporting clinical leaders in making this happen. And we might want, for example, to look at perhaps twinning with an integrated system in another part of the world, learning from clinicians there, so that clinicians in Northamptonshire can actually see what a day in the life of a clinician working in a much more fully integrated system might look like. Because your clinicians are working incredibly hard. You know, you have an incredibly busy general practice in Northamptonshire, with relatively low numbers of GPs, and I'm sure that you've heard about the pressures that your hospitals are experiencing. So this is going to need some added ingredients if we're really going to make a success of that. And then finally, just on our engagement with patients and carers in particular, and voluntary sector organisations. We all know from our personal experience that we see the health and social care system impacting on our families. I see it impacting on my mother with dementia. I'm sure that all of you have those experiences. There's a huge contribution that individuals can make. So the programme needs to make more space and needs to ensure that at a detailed project level and at a higher level, we're making best use of that expertise alongside the clinical expertise. And I'm confident that taken together with the strength of the compact of each of the organisations will give you a very successful programme. This is a good start, but the message I want to leave you with is that there's still a considerable amount of work to do. We do need to power it up, and that would be the message that the overriding message that I'd be wanting to leave with you. Just moving to the Better Care Fund, obviously I've been aware about the debate around the Better Care Fund. That's been focusing very much, hasn't it, on coming to an agreement that suits all parties financially, and that's an essential part of making an integrated care system work. But if we go back to what the essence of that was about, the Better Care Fund was really a statement from the leadership of the NHS in England that integrated working is the way forward, the things that I've been talking about. Now, along the route, we have to sort out some of the things that enable it to happen. One of them is money. There are others, for example, like information exchange that I haven't mentioned that we'll need to be focusing on in the future. Now, it's really important, therefore, that we've got an agreement, because what we now need to do is, having got that agreement, is to move forward and start to mobilise those programmes in the way that I've described. So, Chair, I will pause at this point. I haven't gone through the paper in detail, as given that you want to focus primarily on Better Care Fund, but obviously I'm happy to take any questions on any of the programmes. I'm sure that Chief Officer, Chief Executive colleagues would be happy to do so as well. But at this point, I'll hand over to Pat, if that's your wish, to take us through Better Care Fund.
Unless there's a technical question you wish to ask of Eamon at the moment, I think what I'd prefer to do is to take the presentation from Pat in terms of the Better Care Fund, of which he's provided some slides to talk to. Okay.
Okay, thank you, Chair. Yes, members of the board should have in front of them a brief set of slides. So I just want to kind of build on some of what Eamon's been saying about the work we've been doing around the wider Care Closer to Home programme, which is integrated care closer to home. That's a key point. And update on kind of the journey we've made around the BCF in the county. So I'll just start by recapping in terms of what the primary objectives of the BCF are. And Eamon's last point, it's about promoting integration across health and social care, first and foremost. It now has a single key target within it to reduce non-elective activity by 3.5% in our acute hospitals. It's about strengthening out-of-hospital community services. There's a specific requirement in the policy to protect adult social care services. And I think what's been increasingly evident to us as we've worked up the Better Care Fund together is that it's actually also, I think, encouraging a whole system approach to risk and the management of risk within the system overall. So on to the second slide, just in terms of the pool fund itself, I think I have to start each time on the BCF with it is not new money. The amount of people who've approached me over the past 12 months saying, can we have this out of the BCF for this, that or the other? So it's worth reiterating there is no new money in the BCF. There's a minimum value that each health and social care economy has to put into its Better Care Fund, and for Northamptonshire that's 44 million, of which the NHS contribution has to be 40 million. That is a minimum, and it's open to the partners to increase that to whatever figure they think will best promote integration in their area. We have debated, I think, all ranges really, from the minimum through to the maximum in terms of pooling all of our budgets. And I think one of the things that's not directly related to where we are with the BCF on the 9th of January, but going forward, is that we have done work around what a bigger pool would look like, or what a series of pools connected to the BCF would look like. So looking at adult mental health, learning disability services, as two other areas where we wish to work really, really closely. And I think the principles that we've described in terms of transparency and openness, understanding each other's pressures, and we've revealed some interesting things about the way sometimes our savings programmes don't always align. There is a performance element within the BCF fund, which is linked to the 3.5% reduction target, which is quite technical, and I won't go into that in great detail today, but it is an important area that we've had to cover in developing the plan. The BCF assumes a shift of activity and funding from acute care to the community, and again, picking up on Eamon's point, that is why it's so important that engagement with our provider colleagues in the acute trust is key to this. And certainly over the last month or two, through the Care Closer to Home programme, we have been engaging in some detail with Chris and other colleagues in both NGH and KGH around the Integrated Care Closer to Home programme, the schemes within it, and how that relates to the BCF. I think the last thing to say, and this is probably particularly the case for Northamptonshire, I think in a financially challenged health and social care economy, the BCF represents a particular challenge because of the assumptions behind it in terms of money in the system and money available for growth and investment. So that's kind of underpins some of the challenges that we've been trying to overcome. Having said that about the kind of technical aspects of the BCF and what the pool looks like, I think it's important to go back to the actual patient outcomes particularly, and some of the system outcomes that the BCF is seeking to achieve. And first and foremost, it's about improving patient experience of care and achieving that through services that are closer to home and delivered in an integrated and seamless way. And we know that we've got some way to go in developing services that fulfil that objective. There were a number of very specific targets in the first iteration of the BCF, which are still there but aren't linked to the performance fund, which were set at a whole system level. And I think these have been really helpful in focusing our minds about what it is we're trying to achieve in the system overall, rather than just focusing on individual schemes here and there. So you've got an increase in the numbers of over 65s at home following a period in a reablement service after discharge from hospital. We have a target around reducing admissions to residential and nursing home care, which we know Northamptonshire is an outlier in that area. I've already talked about the reduction in non-elective admissions in acute hospitals with a national indicative minimum target of 3.5. We will be doing further work around that leading up to the 9th of January submission in terms of whether we set our target at that level or whether we seek discretion to vary it. Reducing delayed transfers of care and system weights in the system, reducing A&E attendances, and reducing injuries due to falls in the over 65. So they're the key whole system metrics that give a sense of what we're trying to achieve with our communities. And just worth saying that within the Better Care Fund there were a number of national conditions which included the move towards 7-day working, protection of social care and information sharing based on the NHS number. So that's kind of a quick recap of the BCF in terms of the policy and what it's seeking to do. We submitted, as you know, our plan in September. The plan was not approved following review by the National Assurance process, and the main reasons for the plan not being approved related to the fact that we didn't fulfil 3 of the national conditions. So there was a condition around identifying funding for the Care Act implementation within the plan. There was a requirement that we had agreed how the BCF would protect social care, and we hadn't achieved that by that point in time. And the plan needed to be signed off by the Health and Wellbeing Board, and as you know, it wasn't. So they were the main areas of ongoing difficulty, if you like. There were other areas in the plan that were identified as requiring strengthening. I've alluded to a number of those there. 7-day working. We were in the process and have developed a local patient metric, and provider engagement was highlighted as something that we needed to do more work on, which we have been doing through the integrated care closer to home work. So just to talk a bit about where we are now on the Better Care Fund, and there's been a massive amount of work going on between CCGs and the County Council colleagues over the last few weeks. We are in a position, I think, where we have an agreed plan and agreed funding arrangements that we wish to submit as part of our plan on the 9th of January. And I think just to pick out some of the key themes of that. So I think one of the key themes clearly is that we are very directly positioning the Better Care Fund as a key enabler for and aligned to the integrated care closer to home programme. So the funding and the schemes that are within the Better Care Fund are key elements of that programme which feature integration and require integration across health and social care. We have agreed a revised protection figure in relation to social care of 5.4 million, and that will be linked in terms of the protection element to the core social care offer in terms of supporting system flow through the health system, through so hospital discharges, through reablement services, so that as far as is possible we maintain the levels of flow through our combined health and social care system, and recognising that that's challenging to both parties. The £1.5 million of Care Act funding is now included and identified within the plan, and the principles of risk sharing have been agreed. There is further work to do on that in terms of some of the detail between now and the submission on the 9th of January, but the broad principles were agreed yesterday. There will be further discussions with the acutes around some of the risk share elements as we go into the contracting round with our acute hospitals over the next period. And finally, the pool budget value has now been increased to £59 million, whereas it was just over 44 in the previous submission. The main reasons for that, there have been a number of variations, but the main big-ticket items are the inclusion of the specialist care centres and the inclusion of the community nursing service budgets within that. And those areas were identified for inclusion because, again, they are key to our delivery of integrated care in the community. So that's all the background. I think it's probably helpful to give a few examples of, so therefore, what does the BCF actually mean? What will it mean in terms of delivery of services to patients and service users and carers? And there are, within the Integrated Care Closer to Home programme, over 20 different schemes and initiatives that are covered there, and a number of those are related to the Better Care Fund. I think one of the key themes that has come out as we've done the work around integrated care closer to home is that we have to look at the whole system. We have to understand the way that patients flow either into hospital or out of hospital, and the interdependencies between services. So this is very much part of a whole package. But just to pick out a few examples of where we're already working on delivering services in an integrated way that will be supported through the Better Care Fund, or where we have plans to do so. I've just picked out half a dozen or so examples here. So one key area that we've highlighted through the Integrated Care Closer to Home work is that we need to develop a more integrated intermediate care service. We have added a number of different services and schemes over the last few years to deal with specific problems. We recognise the need now to commission a properly integrated intermediate care service, which would have both bed-based and community elements, and all the ingredients of those services are included in the BCF. We have developed this winter an integrated discharge team, which comprises colleagues from acute trusts, from social care, working together to facilitate the discharge flows out of the acute hospitals and acting as an interface with the services in the community. We've also funded additional domiciliary care capacity to support discharge from hospital, and again that's something we'll be seeking to build on in the BCF going forward. We are in the process of establishing collaborative care teams to work with our most vulnerable patients and members of the community. Those teams will be built around primary care, but they are linked to the social care reablement services, and they will be working closely with integrated care teams and the community nursing services. It's very early days, but I know that the collaborative care service in Corby is working well and already having a really positive impact. And as that model rolls out across the county, that will be a key plank, I think, of the services delivered under the Better Care Fund. We've established an acute psychiatric liaison service, which fits as well with what you'll be talking about later in terms of the crisis concordat, which means that we have mental health services in both of our acute hospitals working in A&E. That is an integrated service with psychiatrists, CPNs, psychologists and social workers. That should impact on what we have quite a high volume of admissions from people with mental health issues who are admitted for very short periods of time into our acute hospitals. This is only a couple of months into action. I think the general feedback from colleagues in the acutes is that it's now beginning to have an impact. There's a national evidence base that suggests that investment in acute liaison has a 4-to-1 benefit to the system, and we will be working with people on the hospital wards in terms of facilitating discharge, but there are other benefits in terms of working with people with medically unexplained symptoms, frequent attenders, etc. So those services are up and running, and they are now mandated that I think by 2019 all health economies must have commissioned acute psychiatric liaison services, so that it's good that we have those in place. We have an integrated crisis response and falls ambulance service, which is another key element of the Better Care Fund in terms of reducing falls, and the work that we've done again looking at acute admissions on any given day. The numbers of people who are coming in with falls is still quite significant, so the prevention element is something that we'll be looking to work with our public health colleagues on there. And last example this year, our current reablement services have historically not really been that well set up to deal with people with dementia. In the course of this year, we've established dementia reablement service with both bed-based capacity and community teams, and we're looking to develop and strengthen that again as part of that wider development of intermediate care services. So I hope that gives you a feel and a flavour for the kinds of things that we think we can achieve for patients by working in a more integrated way and using the funds available in the BCF. Thank you.
Pat, thank you very much indeed, and also to Eamon as well. I think that what I'd like to do is, first of all, invite the chief execs of the organisations, if they wish to add any further comments, before we open it to the members to ask questions of the various aspects. Ben?
I guess just a couple of things. One is just to recognise the work. I mean, there have been people who have been working virtually full time on this, ever since the discussion we had in September under very difficult circumstances. So I think to get to the point we've got to today is a significant achievement. I think the other piece to say is just to reiterate the point that I think Pat was making about the environment within which we're working and that we're trying to come to an agreement about the Better Care Fund. So the point that Pat made is right. There isn't new money. There's not more money that's been created that enables us to do this. And both in health and social care, there are savings that need to be made next year and going forward because of for a whole set of reasons that I know the board are familiar with. So what the process is really helping us to do is to understand how health and social care are planning to make those savings and how we can work together to mitigate the impact of those and ensure that we're not only stopping things getting worse, but they're actually making things better because we build services around the needs of individuals, not around the needs of organisations. But I think it's just important that we recognise that's at the heart of the work that's been going on.
Absolutely agree with what Ben said, and again, I think as we need to give a big thank you to everybody that's been involved in getting us to the point where we've got to. I think what's really important that we should all consider is the word integration, because if we do not integrate our services, we will not be able to deliver on the BCF, or we won't be able to deliver at all. It is absolutely key, but for us to be able to do that, we need a change of culture. We need leaders across the health system, health and social care system, to actually support this and enable this to happen.
Thank you. Carolyn, on the...
Really just echoing what my colleagues have said, we have been working really hard over the last few weeks, and I think the main thing is we've never lost sight of the fact that however difficult it's got, that this is the right thing to do. And we do believe that, and we do believe that by integrating we can deliver better outcomes and actually working closer together. So, yeah, it's been a difficult time, but I think we're there now.
Right. Open to the members of the board. Questions, comments, queries? I'll start with Chris, and I'll take a note of everybody who wants to speak.
Thank you much, Steve, Chair. And I'd just like to say I'd like to thank both Eamon and Pat for their contributions. It was very interesting to hear what you had to say, gentlemen. One question that came across, because the words I put down here is best use of expertise, integrated working, whole system approach to risk, etc. All agree with that totally. And I have a particular interest at the moment in NHS premises. I'm trying to get the NHS to open up to opportunities that may be there in the growth agenda. And I just got a question to ask really for you, Chair. Is there a strategic approach to how we best use the health and wellbeing estate in this county as to are we getting best use? Because so far in this presentation, I don't think I missed it. I don't think it's really been touched upon. I'm just wondering if that's part of the overview of how you use your estate as well. Thank you, Chairman.
Yeah. I think, Will, you had a point. I'll come back to the estate issue when we get some of the comments from the members.
Okay, thank you very much, Chair. I've actually got 5 questions and a comment. Do you want me to rattle them off and then we...
Yeah, why not?
Sorry about that.
I'll make a note so that they get referred back.
Oh, that's very kind. Of the 59 million, and like Chris said, thank you very much for the presentation and the information is really appreciated. But of the 59 million that's referred, could you specify the NHS element of that for me? Could we have assurance that NHFT, KGH and NGH are fully bought into this and fully subscribed to this plan? On the plan itself, of the 3.5% or the minus 3.5% NEL, could you just say some words about how that compares to current year performance and the likelihood of that being achieved and when the target is and what the trajectory is? On the dementia reablement beds, could you specify whether they're new beds or existing, how many and where? And then my final question really is, we all buy into the integrated care close to home thing, I'm sure, but are EMAS, mixing now BCF and Healthier Northamptonshire, so they're sort of integrated in my mind here with this, are EMAS on the implementation board? And well, that's my question. Are they? And then my final comment really is: have we explored different models of care that are being implemented apparently successfully elsewhere, such as, and I'm just going to cite one, Lincolnshire's Community First scheme. They've got a Community First scheme called Lives, and I just wondered if the board had looked at that and looked at, if you like, different apparently successful models in differently structured rural communities or, mixed rural-urban communities. But Lincolnshire's well worth looking at, and I wondered if that had been looked at, and if not, whether that was an opportunity to add even further value. So those are my points. Thank you.
Thank you. Before we go back for queries, are there any more questions? Heather?
Just a quick query from me. Obviously, anybody who goes into hospital, services are provided free. And as soon as they move over into our social care, they're no longer free. And it's how, merging this together, we overcome that difficulty of families not having to contribute in any way while they come under hospital care. But when they move over to social care, we're in a completely different arena. And it's the merging of that. I'd be interested to hear what comments there are on that.
Dominic?
Thank you. Just a point really in terms of hopefully useful to take part of the conversation really is the reality in terms of the connection with what's currently happening now. So I think the plan clearly has moved on in terms of the focus and the elements of the community services and the discharge seem the right areas. I think we need to be challenging to ourselves as a board around the metrics and Eamon's point about pacing it up. So to understand some of those current issues, blockages that we have now and that are currently going on within the hospital. So within Northamptonshire, we are currently an outlier in terms of the number of people who are significantly delayed, and that impacts on the patients, the families, staff, the whole system. And I think there is something about just getting a bit of a sense check and reality push back to what is currently happening as well as the plan. And that would just, it's a comment, but I think it's something that we need to, back to Eamon's point about the level of challenge and ambition and speed and pace, is take account of that.
Thank you. Any further questions? Jonathan?
Thanks for the presentation. One comment I was going to make was around the concept of looking at other health systems and comparing them in a favourable light compared to our own. And just to comment on that, my understanding is that the Commonwealth Fund in America, which is similar to the King's Fund in this country, as far as I'm aware, ranks our service extremely highly. So we shouldn't lose sight of the fact that we have a lot of good things here, and we don't want to be looking to transform to something else that actually may not be quite so good. The problem will be the cost, of course. But moving on to the detail of this, a couple of things. A lot of this is around transformation of care into a community setting. And, of course, I think that general practice is the primary provider in that sense. Certainly in the public's mind it is. And I wanted to check how far you feel that general practice has been engaged in the decision-making regarding this process and how they would be involved in the delivery of it, what impact it will have on general practice. And secondly, how much patients have been involved in the decision-making around this. Because I think sometimes their desire and their feelings regarding what they would like to have provided may not marry up entirely with our economic aims in terms of the budgets and trying to make it as economic as possible. I'm also concerned that if you provide good quality care in the community, do we have evidence that will really be economically better for us than providing it in secondary care?
Thank you. We have now, Martin, final point.
Just one question from me. Echoing what Will said about adding value, I'm bound to ask, cognizant of the fact there's no new money, what plans there might be to better integrate the involvement of the voluntary and community sector. Looking at some of the outcomes you mentioned, I'm aware that many of the colleague organisations that I represent either already contribute to those outcomes or could contribute more.
Thank you. Okay. We've got 7, 8 different points which I will not summarise, but actually not necessarily come from the top down either. So we'll deal with the estates bit later on. If we could, first of all, deal with some of the points that Will made, which were, in terms of the proposal that's before us today, of the 59 million that's going to be in the pool, could somebody explain what the proportion is NHS as opposed to the social care elements? And also tie into that how the pool will actually work, in the sense of, you've talked about integration. Does that mean integrating people, or is it just integrating outcomes? And are we each going to deliver our same services separately, but in theory together? So in other words, could we start with that first? And I don't mind who volunteers. I'm sure that each of the clinical commission groups and social care will have a comment to make.
Well, I can answer the question around the NHS contribution. So of the 59 million currently, 45 million will be NHS funding. We do have a number of potential investment proposals within the Integrated Care Closer to Home programme that, should they be approved, would increase that funding by up to another 6 million.
Of the 59 that's been quoted, or the 45?
That would predominantly be NHS funding as well.
Right, so let me get this clear. Of the 59 million that is currently being proposed, 45 is essentially coming across from the NHS, and the increase has come out of, has been a social care increase, but you have an additional 6 million that you would be looking to integrate or use
on a save to invest basis. So if those cases are approved through the relevant processes, they would then go into the BCF pool as part of the total programme.
So could you just explain what some of those are? So, because obviously they're not involved in the what will integration mean page.
They include things like increasing crisis escalation capacity, further development of the dementia services, telehealth type interventions, telecare.
Fine, thank you. Could you then, or who's going to deal with the issue about what does integration actually mean? I'll come then to the providers to get their view. What does integration actually mean? Does it mean you will do things the same as you are now, or will you actually, well, what does it mean?
Well, our view of integration is that we will totally transform and do something differently, and that's about, I think, putting our staff together, our services together, and I think it goes back to what Carol was saying about how we lead going forward. And I think what we have learned through this process is, not the need to be precious about our services, but how we can deliver the outcomes in the best way. And so we're very open to how will that work, and if that means that we put staff together and they're under one management of one organisation, then that's how we will progress this. I think the focus is how can we deliver the best outcomes for the people of Northamptonshire, irrespective of which organisation. And I think what we've learned through this process is that we've got over that now. So I think as we go forward, you'll see that change. So I can't give you a definitive model, but what I can say is that we've agreed that.
What about Ben or Carol? I mean, what's your views?
I think one of the things we've come to through this process is simply putting budgets together or putting them in one place without any actual change in practice doesn't achieve anything. There's no evidence that it achieves anything. So we've been focusing our efforts on, as Pat's been pointing out, the change programme that sits behind it, which is essentially the integrated care closer to home piece. So you do get new services, things operating in new ways that deliver better outcomes, and that's where our effort has been and where our effort will continue to be going forward.
Carol?
I think it's exactly what Carolyn and Ben have just said, but it's also about us giving people that are working at that grassroots level permission to be able to work across organisational boundaries. Organisational boundaries shouldn't really exist at all. It's the way that we put the flow into the system and the way that people work at that grassroots level.
So will there be one assessment
Yes.
that we all agree with? Have we agreed that now? Could I ask the providers, because obviously there's a view which was asked, or a question asked, as to how much involved you are and to what extent you're happy with a common assessment?
Well, we were asked by Professor Pope whether we were fully bought into this, and I have to say we aren't fully bought into it yet. This has been pulled together very rapidly with a lot of hard work over the last few days. I spoke to my finance director this morning, and it's very clear that he has reservations which have not been answered yet about the risk-sharing arrangements, which Pat rightly says are yet to be agreed and to be considered through the contracting round. I know that there has been a lot more engagement since the last meeting, which is one of the things that I asked for at the last meeting, that there would be engagement in reaching a final decision on this. And we have been fully involved in this. We do support the general direction of this, and we support the programmes. We think there needs to be more of these things. But it's very difficult, I think, for any of the providers, and I'll let them speak for themselves, obviously, to open-endedly sign up to this in this meeting today, as you seem to want us to do, when this is the first we've seen of this particular version of the agreement. I've read and considered in great detail with both my CEO and my finance director the briefing paper that was around last week and all of the issues that were involved in that, which gave us quite a lot of concern. This is a different version. It's a scaled-down version. But a lot of the detail is yet to be resolved from the provider perspective. I echo Will's comments around what does 3% reduction in non-elective activity mean, and where is your baseline, and what are the supposed commissioning impacts of that for the providers going forward. I don't know. I've not seen any information on that, and I don't think, as this has been pulled together at the last minute, that the executives at KGH have either. So I have to express some reservations. I do applaud the work that's gone into it, and I do say that most of the actions that are on the table are the right things to do in terms of delivering better care for patients. But I am completely unsure as to the actual impacts on the providers of doing these things, because we haven't got the commissioning details yet. And I don't know where the risk sharing will go. But in a week where both hospitals have been seeing incredible increases in demand, been struggling to cope with it, and over the last 5 weeks we've seen 11-13% increases year on year in admissions and in ambulance attendances as well. I'm not sure where the 3.5 non-elective reduction is actually going to come from. It's not happening anywhere else.
Thank you. Chris or Paul?
I agree with what's been said. There is absolutely, though, no movement away from our absolute commitment to healthy Northamptonshire. And I would also draw attention to the work that Pat and Giles from NHFT have done, because we firmly believe that these are the right schemes. My Chief Exec, Dr. Swart, has also given her commitment to free up, where possible, our clinical time to work on the clinical pathways. But the direct answer to Will's question with regards to demand is that we're seeing on average an extra 16 non-elective admissions a day, roughly, approximately half a ward. And when we've worked through these schemes with Pat and colleagues, they equate to about a reduction of 9. So that is about a 60% reduction only on the increase we've seen this year. Now, I'm not making that comment to say that Northampton is any busier than community, social care, primary care, KGH, anyone else, because we are all in that situation. My point is about understanding the risk that is around the 3.5% reduction and how that then frees up the finances available to invest in these alternative mechanisms. But I just want to finish with, we are absolutely committed to making this work. It's how we make it work that we are yet unsighted on, and we need to be able to give you the commitment that you need from my organisation.
Okay, Paul.
Similar comments really to my two colleagues. Are we signed up to it? Absolutely. Are we determined to remove duplication in the system and to, you know, we fully expect to be commissioned for outcome, which is absolutely right. I think the energy and effort that Angela and our team have put into the integrated care closer to home is a demonstration of our commitment to this. We certainly sign up to the principles here in front of us, but you know, as Pat said, this gives us a feel and flavour, I think were his exact words, of what it means, and that's fine. But it's very difficult to sign up unreservedly to something that just gives feel and flavour. I would like to have a chance to talk with my executive colleagues about some of the details here, but principles, absolutely fine.
That raises another question in terms of how do we move this forward from the board's perspective, and on the basis that the Better Care Fund has got a submission to be made on the 9th of January, and the fact that for the next 2 weeks nothing's going to happen in terms of other than dealing with the emergencies that you've actually got within your organisations, it's unlikely that we're going to move heaven and earth to actually create some numbers that everybody's satisfied with. We have in the audience with us Ian Wilson, who's been the facilitator provided through the DOH to help the process for the Better Care Fund. I wonder if the board think it might be appropriate if he was to give a comment as to the points he's heard from the providers who are here. I'm looking at the board to say yes. Ian, would you please join us at the bottom for a couple of minutes? I briefly introduced you. And other than to say that you were invited by the DOH to come and talk to all the parties concerned, and I know I've personally had meetings with you, as have some of my colleagues, as have obviously the people from the CCGs. The comments that you've heard from the hospitals and the provider are clearly of major concern. How do you think that we would be best advised to deal with that?
Well, thank you for the opportunity, and good morning, everybody. There isn't a kind of magic wand around this, and up and down the country these conversations are going on with acute providers about the 3.5% national target, which is imposed upon everybody. And whether that's a realistic target or not is a matter for you to discuss with politicians. That's not my brief. But it is nevertheless a national target, and it's a condition that's applied to all of the BCF submissions that you describe the way in which you are to do that. Now, it's perfectly reasonable that the providers in this situation will say, well, where's the modelling for that? What are the assumptions that underpin that? Because we don't wish to tie ourselves into something that is unrealistic and undeliverable and might affect our finances, might affect our patients. So that seems to me to be all quite reasonable. But it is the fact that the great majority of local authority and health economies up and down the country got approved in the first wave. There were only 45 areas that were not approved, and there were only 5 that were rejected, of which we are one. So there is some evidence from elsewhere that these things are not insurmountable, even in the climate in which we work. So the challenge is to do the pieces of work that establish the confidence locally that the aspiration, the national aspiration for 3.5%, could be reasonably addressed locally through a series of measures, despite the severe challenges you face already. So that's the work that, as I understand, has been going on, and I think we're indebted to Giles and Pat and a number of other people who have been working very hard with your finance teams to try to develop a model that gives you some confidence that you understand what the patient flows would need to be for you to aspire reasonably to that 3.5%. I mean, the truth is that in the course of the financial year 15-16 to which this applies, you could have a pandemic. We haven't had one for quite a long while. You could have a very severe winter. There are all sorts of extraneous factors that can blow this off course. Conversely, if you got a mild winter and you didn't have a pandemic and things were going well in the Better Care Fund transitions and excellent programs that you are doing within Healthier Northamptonshire, of course, with a fair wind, you might find you could overperform. So my understanding of this is you're saying on the provider side, you have a strong commitment to this in principle. You want to make this work. You have reasonable reservations about getting the metrics underneath it understood so that you're not signing up to a blank cheque and you're not signing up to things that are unrealistic and absolutely undeliverable. My conversation with colleagues from your trusts over the last few weeks have indicated that they're working hard on that the model is quite well developed now, and that there is some confidence in it. Indeed, in conversations yesterday, that was repeated as being your people's view, that the model was now a better and more robust model that you could have some confidence in. So in that light, it seems to me that there isn't any real reason why there couldn't be off-table conversations between now and January the 9th to firm that view up, to identify areas where you still have doubts and concerns that need to be urgently addressed, and to get to the point where the submission on the 9th of 9 has in it evidence embedded in it that says we've had these conversations, this is what we found, this is the model, and this is why we think we can now sign up to this. The consequences, of course, of not doing so are very severe for the local health and social care economy. So there is a strong motivator, apart from your passion about great services for patients and getting this right. There's also that in the background.
Yeah. Ian, thank you. Could I invite Graham and then Paul?
In terms of our response at KGH, I completely want to get this settled by the 9th of January, absolutely. We actually have a board meeting on Monday. I'm perfectly happy to take this to the board as a special item with some figures in front of them so that we can actually get consensus around the table, because I know that the execs are not there at the moment, which is why, as I say, I cannot just sign a thing off today. If we can get that through the board on Monday, then you've got our sign-off. But we wouldn't, I mean, you say we're quite close to those more detailed financial understanding of the implications of it. If that's the case, it should be something that we can take through the board.
Would it be appropriate, Graham, if I was available to be able to observe or listen or come to your board meeting to hear? So, but I'd like to think that I was invited.
You're always welcome, Robin.
Ian?
I mean, I know that Chris Pallett has been one of the people who's been very involved in trying to get to a position where the modelling is sufficiently clear and robust. I just wonder whether Chris has got and there was I can't remember whether the meeting was the meeting last Friday, I think, and it might be interesting to take a view, Chair, if you wish.
And that's, yes, you're right. So we've had a second meeting, detailed meeting with Pat and Giles from NHFT, and that is what lies behind my absolute belief that these are the right schemes for us to be doing. I think if we were to try to take a different approach, to be frank, that would be the wrong thing to do. So clinically, we are bought into it. My comments are based on nothing other than whether or not the scale of the change that we need to see to manage our system in integrated fashion are currently available in what we've got. It is not anything around an opposition or a reluctance to take part in this. It is about whether or not the schemes that we have on the table will deliver the reduction that we have to. And I think that is acknowledged. However, at some point, we are going to have to take a leap of faith with this and to understand that if we are to make the system change, then we will have to do something that we haven't done before. So my comments are not about an opposition. They're about understanding the demand and the capacity effects across our entire system of the changes that we're wishing to make. So that is why, following the meetings we've had, my clinical teams and my Director of Ops in particular has been able to say along with me, we believe in this. But what we need to now do is to take back the construct of that and understand the implications in the future and have that discussion at a very senior level, in very much the same way as Kettering, and I'm sure HFT need to as well.
Paul, did you have anything further you wish to add? I have Akim wishes to comment.
Nothing really more to add. If it's acceptable to the committee to give us till Monday evening to converse, then that'd be absolutely fine with us.
Well, we'll decide as a group.
Thank you, Chair. I was just going to comment in terms of process for the Health and Wellbeing Board. We have the option of reserving the complete final sign-off to the Chair and the Vice Chairs with the Chief Officers that are involved between now and the 9th of January. That's a possible option. And I think it comes back to what Eamon was saying earlier on about the Healthier Northamptonshire program is a vehicle to deliver this. There's a set of programs around it. There are clear project plans that we now need to do at pace and at scale, as I described earlier on. And that mirrors exactly what you're saying, Chris. So if each of the various providers and other stakeholders get a chance to discuss it within the organization, because they've just at least seen a formal copy this morning, then that can be brought back to the Chair and Vice Chair with the Chief Officers involved to then sign off, because the principle is agreed by everybody.
I'm looking at the three providers. Is this a solution that allows us to move forward?
I think so. Rather unhelpfully, our board is happening today, so I'll try and take some information as I leave. My question, though, is what would certainly help me is to be very clear on exactly what it is you're asking my board to sign up to and how I can help them through that journey. Is it a sign-up to the principles and the clinical models which are being proposed? Is it a sign-up to 3.5%? Is it a sign-up to releasing cash for my organisation? Understanding exactly what it is I'm proposing would help me greatly in helping to take my colleagues through that discussion.
Have we got somebody who's going to answer that? I'm looking at the Ben.
Well, we can pull that together so that it's clear for people, because I think that's, we need to be really clear. What when we say sign up, are we saying we're signing up to a reduction of 3.5% in the context of a 10% rise in emissions, or are we signing up to here's the best set of plans and the best approach given the situation we're collectively in? So yeah, it's important.
Okay. So does that in part resolve that issue? Would you like me to attend your meeting on Monday?
Entirely up to you, Brian.
We'll have a word afterwards. Paul?
Yeah, I mean, that would be very helpful, Ben. I'm sure that will move it forward. The only question is, when can you let us have that?
I'll do the same.
Okay, so that's tomorrow. Mitten?
Sorry, Chair. Whilst we're discussing the process, which is absolutely important, I just want to throw some reality of what's going on with that 10% admissions, because having had the first-hand experience a couple of days ago at Kettering, our frail elderly population are getting admitted into the wards and not getting the best quality of care we can give them because of the system being so completely full. I think I fully appreciate that we need the finances and the organizational boundaries to be sorted, but this is a must. This is not something that we can get out of, is the reality. And I still would like to remind us, because we haven't done that discussion that Will and Dominic raised about the here and now, because this pressure is real. This pressure is sitting where we're sitting right now in the middle of winter. So yes, we need to carry on with those conversations and get that sorted, but let's remind ourselves of the situation we're facing. And if we're not going to sign up to this, the alternative is what we're seeing right now.
Okay. Could I move on? There are a number of issues still to be answered in a sense. The issue about, well, let me take the point that Heather Smith raised with regard to hospital-free social care cost money. How is that going to work within this new integrated system?
Okay, so we have a system, as everybody knows, where health is free, but social care you have to be eligible, and then your means tested. So through an integrated model, there is part of the reablement process is if you like, for want of a better word, free. But if people then continue into long-term social care, we will need to still do the eligibility and the financial assessment. It will still need to happen. And in an integrated model, it depends who's lead commissioner. If we were lead commissioner, for example, on some of the issues, then we would do that, and we would continue to make sure that people meet eligibility. We have to. Government is not changing that. In fact, the Care Act brings in an eligibility criteria, national eligibility criteria, and I've raised this when I went down to London last week with some of the ministers to say could be a fundamental sticking block that we may need to unstick. So I think we're going to have some further discussions as we go forward. I haven't got the answer.
I mean, Graham and Chris, I mean, the anathema of NHS would be that anything had to be paid for. So, if you're going to be delivering social care services as an out-of-hospital service, how will that actually work?
The honest answer is, Robin, I don't know.
Fine.
But what I think we need to do is concentrating first on getting models of care right. And not allowing contractual or financial discussions to hold us up, as long as it doesn't destabilise one of the parties. I think the wrong thing to do, based on what Mitten has just said, would be for us to take time over sorting that out first, and then holding up actually delivering the right care to the patients that we're trying to see today. I've clearly sidestepped your question. It's because I don't know the answer, but at least I'm honest about that, Chair.
At least it raises the issue, and we've raised it here, so that it's something that no doubt we can come back to over the next 3 or 6 months if it becomes an issue. If I could go then on to a couple of other points. Both Jonathan and Will made mention to the issue about exploring other models of care. There was reference to the Lincolnshire Lives system, and Jonathan, you made reference to the transformation of community setting services via the equivalent of the King's Fund in the States. I don't know, are there any comments anybody wishes to make about engagement and...
Chair, I don't know whether Carol and Angela have looked at the Lincolnshire programme, but I absolutely accept the point that one of the things we must do is be prepared to adopt very quickly those things that seem to be working elsewhere. The NHS has not been good at that. Just going back to Dr. Ireland's point, you're absolutely right. We should be saying more often that compared with other healthcare systems, the NHS is assessed very favourably. But as we all know, and you're experiencing at the moment, there are improvements that we need to make. And in particular, we mentioned elderly. Actually, the biggest challenge we face is how do we better care for our growing population of elderly people, most of whom are living longer, healthier lives, but there is a point at which they need the support of our system, and often they present with multiple complex conditions. And there was a piece of work done in Northamptonshire a couple of years ago, supported by a consultancy, and Ian Philp, who was previously the National Clinical Czar for older people, said that one of the aspirations the system should set itself is that no older person is admitted to hospital unless they require surgery or they have a life-threatening illness. Now, I can assure you today that if that were the case, if only older people in that category were being admitted, you wouldn't have the pressures that you've got. So now, and there are other healthcare systems who have as a goal an unplanned admission is a system failure. An unplanned admission is a system failure. And so I do recognise the reality. I've been an NHS chief executive. But one of the things I would say is that I've heard it said around this table in the context of the Better Care Fund discussion, Graham used the term, we'll wait to see the commissioner schemes. When I opened my comments, the point I was making is that one of the criticisms of commissioning provision as a model is there is an asymmetry of expertise, but the greater clinical expertise sits in the suppliers. Now, general practice input redresses that somewhat, but not totally. The greater expertise in solving some of this problem rests in your trusts, and you need to be bringing more to the table to solve this problem. And I know that's difficult when you're running very, very hot, but actually it's the active engagement of secondary care clinicians working alongside GPs where that's appropriate that will help us to start to turn this tide around. And one of the characteristics of the NHS in England, not just in Northamptonshire, is that the relationship between GPs and consultants has become more distant. Dr. Ireland, is that true in Northamptonshire? And you've got to change that. If you're going to tackle this problem, you've got to change that. And it seems to me the gap you've got on the Better Care Fund, whilst difficult organisationally, is easily surmountable. And what you need to do is what I said at the beginning, is to mobilise some of these things as quickly as possible, at scale, get more clinicians involved, particularly acute clinicians. And I absolutely agree with you, we do need to get more patient involvement. I can't give you chapter and verse on that. I think there has been patient involvement at a detailed level, but we need to increase that. And there are some systems elsewhere in the world that respected observers, like Chris Ham say, it's worth our while looking at. And what characterises them is that they tend to look much more at their population and individual people and not the supply system. And again, that's the change that we need to make. So you focus on the individuals. So if you've got your secondary care clinicians with your collaborative care teams focusing on the people we know are going to come in, and it's a small proportion of people who consume 40% of our beds, then you can start to make changes. End-of-life care is the area where there is evidence that you can actually make cost reductions and improve experience of the individuals and their families. If you've got comprehensive registers, not just registers of people with cancer care. So there are things that can be done. Now, they're not easy, and the ideal world would be the Better Care Fund was an extra resource. And in any other business, that would be the case. Let's be honest about that. So you're being asked to do something that's incredibly difficult. And moving forward, the things I've described at pace is constrained by resourcing. I do accept that. But, you know, the Health and Wellbeing Board, it seems to me that one of your roles is to have real aspirations that might seem to be unattainable at this point in time. But actually, you know, we've had some of those before. That's where you need to be going. So I would just leave you with those observations. I know it's not easy, and some of what I've said might seem very aspirational to the doctors working in A&E and on medical wards and the staff working on those wards, but they're looking to you to change that situation, aren't they, as are the patients and the public.
Will, then Carol, and then Graham.
Thank you, Chair. Actually, could I just do two things, really? One is support what Eamon's just said. I thought that was a really helpful contribution, and from a personal point of view, and thinking about this from the people of Northamptonshire's point of view as well, I don't think you are being too aspirational, and I'd like you to continue to be aspirational. So I like everything you said there. Actually, I met with Ian Philp a couple of weeks ago, and you know, this business around an unplanned admission being, if you like, a never event. Never events sometimes falling into disrepute, I realise, but nevertheless, that this was the basis of my question about EMAS, really, whether EMAS is on the implementation board for Healthier Northamptonshire, because actually, if you talk to EMAS, what they know is that they are conveying into A&E people who they would prefer not to be conveying, so out of care homes and so on. So what I wonder is, are we in this aspirational change, have we got the right players around the table who've got the right information to actually make those changes? And I wonder if sometimes we don't have the aspiration that Eamon's pleading for, which I think we should have, and if we always have the right players to make an impact, because we actually need to make these impacts quickly, and some of them we can make now if we change. If we don't change, nothing will change. So we have to change.
Carol and Graham.
I agree with all the points that I've made, and I think Eamon covered the integrated care closer to home elements very adequately. What I would like to say, though, around the evidence-based interventions, all the interventions that we've identified to take forward are evidence-based. We've had high levels of clinical engagement with each of those interventions across the system, from primary care, from voluntary sector organisations as well, right the way through to acute clinicians. We've worked with patients to be able to get the schemes to where we need to get them to. Not across the board, not across all schemes, because the schemes are at different points around implementation. Some of them are already up and running, some of them need tweaking, some of them haven't got off the ground yet. So we need to be clear that we're actually having to stage this across the whole system at different points. The EMAS issue is a big issue for all of us. EMAS are around the table, around the strategic resilience, system resilience groups every week, and we have those exact conversations with them. So they are there, they are engaged. We're also acutely aware of some of the issues that EMAS are faced with in terms of when they go to a patient's home. If the patient demands to be taken to A&E, they have to take them, whether or not EMAS's decision is to take them or not. So sometimes they don't have a choice. What we have to put in place are other services like the Corby Urgent Care Centre that EMAS then have an option to be able to take people to. Exactly the same with a care home situation. If the care home demands that patient to be taken, then they have to be taken.
Graham.
Thank you. Just want to respond to one part of what Eamon said there, and I refuse to come across as being defensive about this. The point about clinicians working closer with GPs is absolutely well made, and it is the way forward. And it is actually, if you're familiar with our 5-year strategy, very much the direction we want to go. But I do recognise, and I'm not a lifelong NHS person, but I do recognise the challenges of getting consultants who've been in the service for 20, 25 years, who are under tremendous pressure and are sceptical about these sorts of moves, in trying to get them to change in this way in a short period of time. It's almost like, I for my sins, am a Burton Albion fan, and it's like trying to get us to get into the Premier League in one season. Well, it's not going to happen. We've got to get to League One first and League Two, and probably somebody needs to come along with £100 million to buy a few players for us as well. So you have to have all the ingredients in place, and you have to have a long-term plan. And I think it's okay saying, get the clinicians on board. We can do that, but that's not going to happen overnight. That's just not real.
Thank you. Jonathan, and then Mitten.
Just a quick comment on the quote you said. I didn't quite get who had made the comment about elderly people only being admitted in theory if they had.
Okay.
Right. Is he a doctor or she a doctor? Right. Surprising comment, I would have said. I would have thought that the criteria would be that when it was useful to go into hospital, and that people of any age should be admitted to hospital when hospital care was appropriate. And it's a very surprising comment to have made. Thank you.
I mean, he can obviously speak for himself, but I suspect that he's making the comment on the basis that patients' needs are being met, but without them unnecessarily being admitted into hospital, and certainly for long periods of stay. I'm sure, Dr. Ireland, you'll have seen the deconditioning effect that often happens to older people when they're in, unnecessarily for long periods of time. I think there is, within this country, there is a debate, and there is change taking place in the way elderly people are being managed in hospital, with a move towards much more acute ambulatory care, so that we get much shorter lengths of stay. You get the information you need as a GP about what's happening with your patient. What I was alluding to is that you have access to an expert clinical opinion if you need it, either over a phone, in an outpatient appointment, or through a rapid acute ambulatory assessment. But actually, most of our acute hospitals are not designed in that way. And what we see is long lengths of stay, extensive investigations, and deconditioning of a lot of older people, and then the consequences of that coming out into the community. Now, there is evidence from other systems of a different way of doing things. I do accept that if you've been working in a particular way for 20, 25 years, it's not easy to change, which is why I suggested the twinning. You will not change all of your clinicians overnight, but you need a small number of them, dare I say 10 to 20% of them, who are willing to lead the change. If we can't find 10 to 20%, I'd be very, very disappointed. I think you can find that, and over time we can get more coming with us. It's also why I made the point about we need to be looking at job plans, because they are working in a particular way. We need to be looking at recruitment. We need to be recruiting people against these values, don't we? Because if we recruit people in who believe in this, then they're going to want to do it. They're going to be treading on your toes to do it. Now, that's not the situation today. I entirely accept that, Graham, but it has to start somewhere, doesn't it? It has to start at some point.
Thank you. I've got two final speakers, Mitten and then Darren.
So just quickly...
Come in after that.
Building on what Eamon was saying, and I think just responding to Graham's comments, I think as GPs we've had to respond and change, I think, 20 times in the last 20 years in different restructuring that's happened. I think the bit that matters to clinicians is patients and delivering high quality of care. And I think as long as those two boxes are ticked, people will engage. And I think sometimes when we start the process around, let's do this to sort the Better Care Fund problem, or let's do this to sort another issue that comes about, clinicians get disengaged. But when we start off on the tone, let's do something to improve quality, and for the patients, suddenly you'll find clinical colleagues do get engaged. Interestingly, I had a couple of consultants from Kettering ring yesterday to say, oh, with the elderly patients that we saw jointly, have you considered these 4 ideas? And that's the change we need to bring about. And the only reason that happened was because the GP was on site with those consultants in the hospital, seeing those patients out. So I think that's the step change we need to bring if we want to make it happen. And it will happen, and it will help us to fulfill the Better Care Fund or whatever next that comes around the corner next year or the year after.
Thank you. Darren, and then Ian.
Yeah, and just very briefly to follow up on Eamon's point, I think it requires a whole system clinical leadership that includes EMAS. I think, that historically has been a weak link. And it's about the element of risk that clinicians are willing to take. And I think, but doing that together, I think, that we had a visit down at the Royal Free Hospital, and I think, the mindset that's being changed around the country is one from a consultant base where, you're ill until I prove you healthy, to shift that to more a GP focus where you are well until I prove that you're unwell. And I think, the culture is key to all of this in relationships and clinical leadership.
Thank you. Ian?
Thank you, Chair. I thought it might be just worth re-emphasising the point that this isn't new money, but it is money that isn't going to be released into these schemes until you have sign-off on the BCF plan nationally. And I mention that because you are all signed up to Healthier Northamptonshire, a longer-term programme to solve your £259 million odd deficit over a number of years, whilst at the same time trying to create exciting new services for patients that delight and empower them in the way we all aspire to in the NHS and local government. So what I think I need to emphasise is that those BCF schemes are enablers of next year's Healthier Northamptonshire programme. And if we can't get to the position by January the 9th that your submission passes the primary compliance test, which is that all parties sign up to it, then what you face, whatever happens then, is a delay in the release of those funds. Now, I know how much you care about getting on with these changes for patients, and I just thought it was incumbent on me finally to remind you of the fact that this isn't just about some bureaucratic exercise, it's about the release of real money to do real schemes that make a difference in the lives of patients and their families. Thank you.
Thank you. There are two items which, in fact, have been raised which we have not dealt with. And one is to do with the dementia beds and the issue that was raised about the dementia beds. And the other issue was to deal with the management of the estate of the NHS along with the public sector estate in the county, effectively, and how that's actually being managed going forward to deal with the demands for the future. And in part, we know that we have existing issues at the moment in Western Fable, in Daventry, and in other parts. Not wishing to curtail any debate on it, but accepting that the principle of getting an agreement to the Better Care Fund is dependent upon us around here having a solution, as it were, to go forward. I hope perhaps I could take offline the issue about the estate, and I know Dominic has some thoughts about that, and we could speak then separately and do a paper on that going forward. As far as the dementia issue is concerned, I am assured that we are doing far more today than we did, 2 months ago, and we will be doing more in the future as opposed to where we are at the moment. And could I ask Akim to perhaps summarise in a way the... No, you've already done it.
Go ahead.
No, you've done it on the basis of we have concerns from the providers, quite naturally. We have a need as a board to accept the points that have been made by Ian on the basis that it may not be new money, but we don't get access to this until we can actually demonstrate together. But I need a formal words which allows us to say how we're going to take this forward.
Thank you, Chair. In terms of the Secretariat of the Board and having signed off, I think the very first thing we've agreed is that our colleagues from the provider end of the landscape, who have just sent the papers this morning, would have a copy and a spruced up one that actually talks specifically about some of the impact on the proposals and some of the interventions we wanted to put in place. They will quicken the process of doing that, and they can come back to the Secretariat so that the Vice Chair and the Chair could consider that you've said, yes, you are agreeing in principle and also in spirit and reality, which then means between now and the 9th, we can sign off as a board, and the Chair can do that offline. The second thing we agreed as action is to look specifically at elements of the proposal and interventions that we need to quicken pace on, that we need to take through the Health and Northamptonshire program, and make sure that the board has a way of monitoring how it happens going forward. And I think that's already built into the agenda. I think there's a third element, which is around some of the enablers that we've discussed. And I think Eamon articulated this very clearly around clinical engagement, data sharing, data flows through the system, the things that we can do something about without even having to discuss money and stuff, because they make the system work. And I suppose, even though you asked me to summarize actions, there's an element about this that I think we shouldn't lose. The last Health and Wellbeing Board, we had a very long conversation about data sharing. We had a Health and Wellbeing Board development session just last week on that. I'm pleased to say we had some agreement. The reason why we didn't bring the paper to the board today because we thought we were going to have this long conversation about the BCF, and therefore we wouldn't have had time to do it justice. So in March, we'll bring the paper back on those enablers. The one thing, though, that the Health and Wellbeing Board hasn't specifically got into is a clinical engagement work which sits firmly within the Health and Northamptonshire program through the MDAC process. And I know we're having some conversations around how does that go beyond doctors to all professionals and all the clinicians in the system. And that might be worth bringing back to the board at some point when we've got some clarity about championing that aspiration from this board. So with that in mind, the two other actions that I think will require some further board conversation is the well-being, health and well-being estate and assets, which might either be a specific paper to the board or part of the well-being development session that is already planned. The last thing is the conversation around added value. We are doing all of this together because we wanted to add value to the experience of patients, clients, and the experience of well-being in Northamptonshire. And I think, Martin, you asked the question quite specifically about how does the voluntary sector help. I think that, again, brings back to fore the role of this board in creating an aspiration of how we work together. It might be that that's another point that we bring to the board for formal conversation about some of the specific processes that we would put in place across the system. I do hope I captured most of the conversation.
Are we agreed to progress on the way that we've had summarised by Akim?
Thank you.
In that case, could I suggest we take a break for 10 minutes now? And can I thank Ian for the work that you've done and all of the parties involved in the work that's meant that we have this presentation. Thank you. Yes, absolutely.